so we can get on with some learning about GI and GU this week. It's week 8 already. 4 more weeks is amazing. I turn around and it's almost done again. GI, GU is chapters 41 and 45. You're going to be surprised how many diagnoses there are in children's world of GI and GU, things that you don't see in the adult world, and some that are exactly like adult world, treated with adult medicines. This week you have diabetes due, you have NCLEX, quiz 5, your dosage calc, the calculate with confidence, and there is that pediatric assessment assignment. Now, I've had a couple people turn it in. I've already scored them. I want to let you know that if you turn them in a little earlier before Sunday, I will look at those assignments and I will send you back feedback. If I think that you could improve something and get a better grade, I'm going to tell you, if you did this, you can get a better grade. Or if it's coming through with a high plagiarism checker on it, I can say, hey, this is having a high plagiarism checker. This is what you need to do in order to get it down to where I need it. So I will work with you, and you can resubmit it all through the same tab. I have unlimited amount of submissions, so you should be able to submit it, 10 times if you needed to. So that is open and what I will do for all of you. As I see them come in, I will be looking at them and sending back your feedback as soon as I possibly can. Okay? So we are going to be going over the PowerPoint first, and then we're going to be going to our Kahoots. I sent you something in your inbox, but I'm going to put it here again for you. It is just like the respiratory and cardiac. It is a matching again, 20 questions. It shows diagnoses of GI, GU, specific to children, most of them. So it is a really good tool to use. You can use it as you listen to class, or you can go after class another time as you're studying, you can fill it in. I will be sending you also the answer key to that too. So you're going to have that also. So let's go ahead. Let's start with our PowerPoint. So GI, GU. Week 8. So in GI problem and GU problems, the biggest one that we will see is urinary tract infections. Most common, little girls have short, little tiny urethras, and the anus and the urethra are so close to each other that, during that potty training time, they just wipe it and E. coli into the urinary tract system. So very common thing that can happen. Also, uncircumcised males, if you don't pull that foreskin down and get that substance between there called schmegma, clean it out, it is like a petri dish for infection. So it can cause also urinary tract infections. It needs to be pulled down and cleaned. They say minimum of once a day. If you can't pull that foreskin down, it's tight, it's called a phimosis, Phimosis. And it's something that either that you can work on to loosen, or a circumcision will need to be done. Now, any child who exhibits signs of uncomfortable about their urine, urgency, frequency, or you see them, just touching themselves and, jumping back and forth. You know what kids do? They go leg to leg, like you have to go to bathroom. And, you can see them running, or all of a sudden your child's incontinent who's been potty trained for a while. Suspect that there's a urinary tract infection. And of course, if you can smell it, that makes it easier too. So how do you prevent urinary tract infections? Well, with children, increasing fluid intake is probably the best thing we can do to keep that body flushing. Also, in a girl or boy, make sure that they know how to wipe from front to back. Biggest thing that happens with young kids is that they're wiping the wrong way and they're putting the stool, where it shouldn't go and creating these infections. And of course, washing hands all the time. Also, they're saying with adolescents, young girls who, if their choice is to be sexually active, if they can urinate as soon as possible after intercourse, it can help decrease the amount of urinary tract infections, especially in those adolescents who tend to get more frequent infections. So once we decide there's a possibility of urinary tract infection, number one, we're going to do a urine culture and sensitivity. As we've said, with children, the young ones, we're going to do a catheterized specimen. It is the best, most accurate one. And, it's uncomfortable, but it doesn't hurt. And it's better to go ahead and get a proper culture on these children so that when that culture report comes back, we know that child's on the proper antibiotic and there's no delays. Because in young children, we can really damage their kidneys if we don't get the right antibiotic in as soon as we can. On premature children, we don't have tiny enough catheters. They're just too big. So what the physician does is right above the symphysis pubis, they'll just clean it with whatever their cleaning substance of the year is, betadine or Hibiclens or soap or alcohol, whatever they want to use. They'll take and clean it there, and then with a sterile needle, they'll go directly down in there and withdraw urine, because that's where their bladders are. Now, it's uncomfortable, yes, and they hold pressure there when they're done. But again, it's getting that accurate culture. How important is that? We don't want a premature child to go septic because it's urinary tract, because we cannot do a catheterization on these children. It has to be suprapubic. So we do it. And most of these children are already on sedation. So they are paying attention to maybe giving them an extra dose as we're doing that procedure. Sometimes we've got to go in to do a kidney tap because of the infections there. We can look at their ultrasounds, voiding cystourethrographies. These are things done for those children who are having frequent urinary tract infections, and we can't stop them. Maybe there's some sort of obstructive uropathy going on there. Maybe the ureter is kinked, or maybe the valves are tightened or loose and it's allowing backflow. Who knows? But that's usually what's done. They'll inject dye through a Foley into the bladder, and they'll watch it go up and down if there's reflux going on. The intravenous pylography, which is an IVP, many times that's done for renal calculus, kidney stones. So sometimes we have to go in and do a renal biopsy. The thing with this is that it's uncomfortable and they can get nauseous. We're going to use sedation. So we are going to make them NPO for a minimum of 4 hours before. They will be getting something, maybe some midazolam, maybe a little bit of morphine with that, something, because they're going through the back into the kidney. Now, the child could be sitting up or laying on its side, depending on the age of the child and the physician. We need to monitor their vital signs. Now, once the procedure is done, again, just like a cardiac cath, we're worried about leaking. And this would be urine inside the abdomen or coming outside. So a good pressure dressing there. And if the kid's big enough, we'll put a sandbag to make sure that we're keeping that area pressed so that we're not having any leakage going on. We're just like cardiac cath, in bed 24 hours. You can bend your knees in this one. The legs have nothing to do with it, but staying in bed, very important. Try to minimize the risk of urinating, literally, either on the bed or into the peritoneum. We don't want to do that. So we'll be watching for what? Well, if we're suspecting possible leakage, we're going to be watching your intake and output, making sure that their output is good. We'll be watching that dressing for any secretions. And if we're starting to see abdominal pain, that means urine is leaking in there. Something's not going on. So we'll be monitoring that. And on infants, because they're so tiny, they do use a little incision. So, monitoring them for pain afterwards is important. As I said, sometimes there's obstructive uropathy. It could be hydronephrosis. The ureter is going up into the kidneys. The urine can't get down. It could be vesical ureter, which means vesicle, the bladders, and the ureter. Sometimes there's kink one side, both sides. You never know. But as soon as we can correct that and get that flow the way it should, it's going to prevent hurting the kidneys or preventing multitudes of infections. And this is a great picture of it just to show you there could be a kink, something band around it, something, or the tube wasn't right. And then we could go in there and we could try to open it up to make it function. Now, nephrotic syndrome is not renal failure. It has nothing to do with renal failure. Your kidneys are working, but your kidneys are spewing protein out. It doesn't like protein, whatever reason, doesn't want it, throws it out. So what do you see if your kidneys are just throwing protein out in the urine? Well, you see protein in your urine. Then protein's also in the blood too, right? It's that albumin that's sitting there. Well, it gets filtered through the kidneys. Guess what? That's gone too. So hypoalbuminemia. Are going to see your hyperlipidemia, and because now your volume of blood inside the vasculature is becoming more less with protein, it's becoming more hypotonic. It sort of goes into the tissues surrounding it. So now you're going to see edema. You're going to see the facial, the eyes. You're going to see even sometimes the mouth, the tongue gets swollen, and you're going to see overwhelming edema on these children because they've lost their protein like crazy. So that's basically the chart that you saw in your books. It's just telling you it has to do lose protein, and you're also going to go more hypovolemic, means less volume fluid, and you're going to have that swelling. It's going to go interstitial. So I'm telling you that there's swelling, that there's edema. Well, one of the treatments for nephrotic syndrome medically would be steroids. Steroids is used in that acute stage when they're really suffering from nephrotic syndrome and they're having huge losses of protein. Now, the other side of it, it's all about fluid balance. I'm telling you, all of this tissue gets all of this fluid in it, and you're all edematous. So we're going to monitor fluid balance on these children. We're going to watch their salt on these children. And as a nurse, what does that mean? What are we going to watch the most if fluid balance is our big thing? Well, intake, output, and daily weights. Very important things to do. We can see weight gain, we can see weight loss, and take care of them. And we really need to involve this family, especially if there's little brothers and sisters, that can tease them about, you can't have any more soda, I can, or, I'm shaking my salt on my food, and we need to teach that family how important it is for that child not to get it. I had 6 brothers. They teased me my whole life. So I can't imagine having something like this going on and having a brother or sister teasing you. So we need to reduce the excretion of urinary protein. We need to take the steroids, as said. We need to reduce the fluid retention. So we're going to be monitoring how much fluid we take in. It's going to be really lowered, the amount. So it's going to be restricted. And then we're going to be monitoring the salt that's going into this child. Anything that can cause fluid retention, we're going to do the opposite to make sure that we are getting rid as much fluid as we possibly can. And these children are at high risk for infection. Well, I just told you one of the treatments is steroids, immunosuppression in itself, plus the disease itself. So these children are really up to get infections. Another thing in GU is something called acute glomerulonephritis. Remember I told you there's two things that can happen due to an undertreated strep? Well, we know rheumatic fever, right? What's the second one? Acute glomerulonephritis. This is when your kidneys are being attacked from the strep infection that you had 2 or 3 weeks ago. And what would you present it? What would this child look like? Well, they're going to be not urinating. They're going to get swollen. And all of those things lead up to hypertension when we take a blood pressure. One of the things that might get that child to the doctor is the color of the urine. Maybe they're seeing blood in their urine or the darkness from the protein, and that alerts them. And then they start to see, oh, he's not urinating as much. Oh, he's swollen. Look at the eyes, his eyelids are puffy. And then, of course, take a blood pressure. So the prognosis of acute glomerulonephritis is good. Usually it turns around and it's gone, but not all the time. It depends on how quickly that they were treated, the strep infection, which is the underlying cause of this acute glomerulonephritis. Again, we're just going to treat them with the antibiotics that's due. As a nurse, what are we going to be watching? Well, this is affecting the kidneys. Intake, output, I&O, daily weights, right? Fluids, salt, these are all things. And of course, monitoring the blood pressure. Very important on this. And we're going to watch actually the blood pressure come down. We can watch the output start to increase as this child recovers. So again, manage edema, nutrition, and again, be careful with infections on these children. So hemolytic uremic syndrome, it's an uncommon disease, but it's from the E. coli. E. coli from the bowel, again, goes up into the urinary tract, and it causes thrombocytopenia and renal failure. Now, thrombocytopenia, P, platelets, think of bleeding, right? We think of thrombocytopenia, think of platelets are low, any low platelets, we're going to put on, watching for bleeding. And that's exactly what you're going to see with these children, bleeding and bruising and, it doesn't look the same. And that would lead us back to this syndrome here. We've talked about Wilms again before. It's a renal nephroblastoma. And we know that with these children, that they're boys, African-American, ages 3 to 5, will do chemo or radiation, surgery, take it out. And our thing that we need to monitor before surgery is not to touch that belly, because it is that tumor very fragile, and it could cause pieces to break off into the peritoneum and cause a metastasis. Children do get renal failure, whether acute or chronic. Acute could be due to an obstruction, and chronic could be due to either congenital anomaly or something hereditary. Now, acute renal failure is when all of a sudden your kidneys stop working. It could be due to severe dehydration. One of the things that actually we don't think about how severe it is, but dehydration in the child can lead to renal failure very easily. That's why our goal when we're talking dehydration is to get them hydrated as soon as we possibly can. There are also medications that can cause renal failure. I've actually seen ibuprofen cause acute renal failure. And once we identified it, we took them off the ibuprofen and their kidney function came back and they started urinating. So, different things can cause it. Chronic renal failure is when slowly your kidneys really stop functioning and then you stop urinating. Why? What happens with the chronic? Well, it could be some sort of congenital malformations, or it could be some reflux that was never fixed, that you're constantly refluxing dirty urine from the bladder, because the bladder is close to the outside of the body. It can get a little bacteria in there just normally. And then it goes up into the ureters, into the kidneys, which is your sterile area, and it could go up there and really damage your kidney just from reflux if we don't fix it. One of the things that can cause it is hereditary. When I was working at Nicholas Children's, I was doing clinicals for another college, and I was on that floor, the GU floor, which I didn't work at normally. And there was a dialysis unit, and it was full all the time. I'm like, why are kids with chronic renal failure? And the biggest thing most of those nurses told me, it was marriages with inter-family marriages, first cousins and whatnots in some cultures. And I was like, okay, that was their biggest reason for kidneys not working and chronic renal failure. And I thought that was very interesting. I mean, every area, every place, you're going to have your own culture of why, but that just seemed to be what it was here. You can also have chronic pyelonephritis. It means you've got pus going up into your kidneys and severe infection. Chronic glomerulonephritis, if you didn't catch it quick enough and start those antibiotics. Lupus attacks any organ, so that's a no-brainer there. And then anaphylactoid purpura. This is any anaphylaxis can go in, and it can also hurt your kidneys. So management of chronic renal failure, well, we need to try to let that kidney work as best as we can. We know that fluid and electrolytes are very important with children with renal failure. Most children, even adults that have chronic renal failure, usually have also low hemoglobin and hematocrits. One of the medications that we can use to prevent an overuse of just transfusions is erythropoietin, because it makes the body make its own red blood cells. So if we can decrease them having a blood transfusion and everything that goes with that, it's a great choice. So erythropoietin's used on them. And, you know, with any child with any illness of any type, we always try to give them a normal, active life as they possibly can. Because remember, they're still a kid. They still need to be a child. Now, this is a picture of peritoneal dialysis. There's a catheter that goes into the belly, and the belly is your membrane that we use. And what we do is through that catheter, we will put in fluids. Now, there is a warming plate where this bag of fluid sits, and the fluid is whatever the nephrologist orders. It's called a diastolate, is the name for it. And you warm it because you don't want cold fluid go inside the belly. I mean, these are used mostly for your young children, your infants, because they can't use hemodialysis. Hemodialysis creates a big swirl of blood, and these children's brains membranes, the blood membranes are so fragile, it could cause bleeding into the brain. So we don't do hemodialysis. So all you've got is your peritoneum, and it works great. So we take the fluid, put it on the heating bin. We take under sterile procedure, we put the mask, we put on the hair holder, cap. We put on a gown, gloves. It's a very serious thing to keep this as clean and sterile as possible. Because if we get infection inside that abdomen, there's no other place to take care of urine. This is their kidney, so we need to protect it. So peritonitis is your biggest fear of all with peritoneal dialysis. As a nurse, what are you going to be watching? Now, whether you're trained to do peritoneal dialysis or not, The one thing that we are watching always is the color of urine that's coming out. If we are seeing the color change or we're seeing sediment that's not normal, we need to call that healthcare provider immediately because it's showing signs of infection. And especially if that abdomen gets tender, something's going on. We need to protect it because that's all we have to remove toxic waste from this child. What's great about peritoneal dialysis is parents can do it at home and keep their children at home. And actually, children do very well. I saw one child who, up to the age of almost 2 before he got his kidney, he was done by his parent every night. And that mother could put a dressing on almost as good as me, and I'm OCD. That kid was perfectly kept, never had peritonitis because she followed the routine. So it can be done really well. So what best describes acute glomerulonephritis? Which one? Anybody?
B.
It is. It's from a streptococcal infection. Yes, it is. So if it's from a strep infection, treatment, antibiotics. All right, let's go into GI. Now, GI, mouth to anus and everywhere in between. And there are things that you're going to see that you didn't even know that there were diagnoses. So one of the things that can occur with GI issues is nutritional disorders. That means they're not getting the vitamins they should. I mean, when you think of celiac disease, you're talking about your fat vitamins, you're talking cystic fibrosis. Again, you're not absorbing everything that your body needs. So one of the things in children, we know nutrition is like the most important. Helps with growth, helps with cognition, that we need to make sure that nutritional needs are met. And if they're not, making sure that these children do get the supplements they need, or they're going to have growth failure. Another thing with foods is food allergies. This is why when the child is 6 months old and we're starting to introduce food, we're not introducing it, 3 different things in a day. We do 1 every 3 to 5 days, introduce a new food. Once we don't see any problems, we go to the next. What problems would you see? Well, sometimes it's a rash that looks like that. Sometimes it could just be a little bit of eczema or dry skin in the folds of the arms or behind the knees. You might see stuff like that. Or you might see vomiting, you might see abdominal pain, constipation, diarrhea. All of these things could tell you that there's an allergy to food. We know usually the first thing that we see with food allergies in children is that lactose intolerant. They're unable to have milk, and that's why they go into the soy formulas and other types because of lactose intolerant. But then it goes into all the foods. GI dysfunction can lead to growth failure because we're spitting up food, we're spitting up stuff that should be calories and nutrition, and we're not getting it. Therefore, you're not getting what you need. Therefore, there's going to be growth failure. We can have nausea, vomiting, diarrhea, constipation, abdominal pain, gas, distension. All of these things can come from GI dysfunction. Jaundice, I mean, the liver is right there in the common duct. If things happen with the liver, it's going to cause jaundice. There's also something called dysphagia, or inability to swallow, chewing. One of the diagnoses that can cause that is something called Pierre-Robin. And Pierre-Robin has multi things that go on with it. They can have problems in, hypospadius. They can have cleft lips and palates, tiny little chins, and it's hard to swallow. So dysphagia. And GI dysfunction can occur because of fever. What does a fever do to the body? it burns off fluid. Therefore, fever can cause dehydration. And we know dehydration causes a lot of problems. So remember, with fever, children should be getting more fluids than normal. So dehydration is whenever the output of fluid exceeds what you're taking in. That means there is not enough fluid in the body. Could be due to the fever. That's biggest, number one. It could be due to vomiting, diarrhea. Now, this little baby sitting here, it's a great picture. It looks like it's sort of sitting in mother's arms, but do you see how indented that fontanelle is? And that kid looks quiet and calm. That is a depressed, sunken fontanelle. That's telling me this kid's dehydrated. But beyond that, look at the color of that child. That color looks pale. Even the ears are pale. Even the nose is pale. This child is severely dehydrated and needs fluid replacement. As just a look of the child, you can see it. So accurately measuring intake and output, we can measure urine and stools, we can measure vomiting. If the child's under strict INO and are sweating, there's ways we could put pads underneath children in order to figure out how much sweat that's going on. Vital signs tell you a lot. I mean, dehydrated, elevated heart rate, decreased blood pressure, absolutely. Prolonged capillary refill, you're going to see decreased urine output. You're going to see decrease in body weight. All of these things are really showing you this child's dehydrated. And those fontanelles I love. It's like you can look at them and see, is it bulging too much or is it sunken? It's a very good thing to have as an assessment tool. As a child gets older and they are becoming dehydrated, they tend to get a little bit confused, and they tend to not be fully conscious and asking things. And the parents like, what's going on with the child? Well, it has to do with dehydration. Diarrhea can be all types. From the most common of diarrhea is because of antibiotics. I mean, that's number one that you'll see. It could be due to an infectious gastroenteritis. It could be a chronic, or it could be something that happens with children and they're really not even sure why, but some kids do. Now, with diarrhea, we're going to make sure that we take care of the fluid that's coming out, you know, and the diarrhea, that we're going to replace it. And remember, as they're losing fluid, they also are losing electrolytes. So make sure that we give fluids with an electrolyte component. Now, diarrhea, unless they're unconscious, you're going to feed them orally, okay? There's no reason to have to put an IV in them because they're not vomiting. They are able to take food in. Now, it's not to put the kid on clear liquids. Please don't do that. If you put a kid with diarrhea on clear liquids, what's your stool going to look like? All you have is liquids in there. So you're going to continue with liquid diarrhea. So make sure that, you know, you tell the parent, just a low fat something. Give them, you know, toast and crackers, and you can actually bananas. There used to be this thing called a brat diet, which they don't believe in that anymore. Let the kid eat what they want within reason. That's low in fat. I mean, most kids like a piece of toast or a cracker or something, which is actually a better choice for them. Children can become constipated, and constipation can actually lead to urinary tract infections. So stool moving frequently is an important thing in children. Now, one of the things with children, the one thing that they're able to control is their bowels. And they can control their bowels so they don't go, but maybe every 2 weeks. And they're doing it for some sort of attention. Usually there's something going on at home. they had to move, or, mommy and daddy got divorced, or, grandma, is no longer here. Something happened. And these children use this constipation as, I need someone to pay attention to me. And they do it by holding their bowels. I've seen if you look at an x-ray, the whole bowel is full of stools. So you give them an enema and they will get rid of it. There is a PD Fleet enema that we give, and they can get rid of all of the stool that's in them. And making sure that children pass several times a day, soft stools, important, especially, as I said, with UTI. Now, we've been talking about constipation, and we've been talking about this for a couple weeks. And what are things that we would see that an infant newborn is not having a stool within the first day, day and a half of life? Well, we've talked about hypothyroidism already. We've talked about cystic fibrosis already. Well, Hirschsprung's is going to be the next one we're going to talk about. And if there's any narrowing or non-opening, of course, that's going to cause some sort of problems with constipation. So constipation during infancy, we've checked it, we found out what's going on it. And the kid's normal, but tends to be a little constipated. And there's kids like that. What we have seen is that breastfed infants usually stool almost every diaper. It's just what they do. It's usually constipation is from formula-fed infants. Usually that is what causes constipation. And sometimes the physician looks at, well, how many calories are in the formula that you're given? Maybe we need to, put something else into the diet to help them move their bowels. But as I said, formula is more than your breastfed. Now, Hirschsprung's, this is something that you're not going to see a stool in the first day, day and a half of life. It's called a congenital aganglionic megacolon. Basically, there's an absence of ganglion cells in the colon. Well, what does that mean? There's no nerves in the intestines in this descending part of the colon. So there's no peristalsis. And when it stretches with everything that's coming, the child doesn't feel pain. So you might feel that abdomen and you might feel this huge something there, and it could be this megacolon. Now, if you look at the bottom where the rectum is there's a tiny little hose there, right? Sometimes a little bit due to pressure, some will squirt through and it's ribbon-like stools. That's one of the symptoms, signs of Hirschsprung's. Just a little bit like squirts out, almost like a pastry, with icing you try to get out. Same look thing, just a little bit comes out. So how do we take care of Hirschsprung's? Well, Hirschsprung's is a disease that the bowel, it's not workable. There's no nerves. It doesn't work. It needs to come out. So once we look at the picture of the x-ray, we're going, okay, looks like it. We're going to go in, do a biopsy. And in that biopsy, we're looking to make sure there's no nerves there. And that is okay. Now we have our diagnosis. This is Hirschsprung's. They'll go in and take out that piece of bowel, and they will give this child a colostomy in the first couple months of life. That gives that area lower a chance to rest, and the upper one to rest, and making sure that it's all working good, and then they'll reattach it, and these kids do actually very well. So Hirschsprung's is no nerves, doesn't work, ribbon little stools, and we need to get it out and put a colostomy. Now, vomiting, there's all different sorts of vomiting. So if we have a child who's vomiting, it's just, you see it coming down their face. Remember, they're losing a lot of fluids here. This kid is just refluxing. That's, okay, it happens. But vomiting everything that they're eating. You know, we see it's just everything's coming up and you see them retching. What is a treatment for a child with vomiting? Well, remember, dehydration, we worry about. We worry about a lot. We don't want it to happen. So if you're vomiting, can you give that child something by mouth? No, they're just going to vomit again. So in acute vomiting, the treatment is IV fluids. And if we're starting an IV, we're putting a needle in the vein, get a metabolic profile, look at what the potassium is, see what's going on, see what the blood sugar is on this child who's been vomiting and vomiting, okay? And do not feed that kid until you've given them some medicine, given that chance of that tummy to rest. And it could be an hour, half an hour on medicine, and then slowly return diet. So I briefly mentioned gastroesophageal reflux, GERD, okay? GERD is just that little spit up that you just see in the mouth. And remember, they're losing calories. Now, sometimes reflux is so bad in infants, the baby's burped, positioned properly. We have started them on Pepcid. We put them on some Prevacid, and I can name the medicines down. They're just like adult medicines, but in baby milligrams per kilogram, okay? Same medicines, there's no difference, and they're still refluxing. Well, remember, reflux can cause aspiration pneumonia, and that's our biggest concern. So many times they will decide to do something called a Nissen fundoplication, and it is a treatment for that reflux that we can't, through everything we've done, manage. And what it does, it takes the piece of the stomach up so that it can't go up. So you don't have reflux going on. It prevents vomiting, okay? Many times when you see Nissen fundoplication, they do it with a gastrostomy tube, because if we're putting big boluses of food in there, we don't want it to come up and reflux. But the other way we use this Nissen fundoplication is when a child's really bad refluxing and we want to prevent the damage to the lungs from that aspiration. If you look up here, older children with reflux, you're going to hear them coughing because that fluid's trying to come up, and then they're trying to aspirate, so they're coughing, and you're going to see them with heartburn and abdominal pain. Again, same treatment as an adult. Put them on the medicines, see if it calms it down. If they continue and it's bad and they're refluxing and aspirating, again, Nissen fundoplication is what they do. It just pumps it over so that they cannot vomit. Acute appendicitis, same symptoms, same everything you see as an adult. You will see a child bent over, holding the right leg and limping. And that's usually what you see in this poor child. You're going to see the McBurney point. You're going to see the rebound tenderness, same thing. Our biggest concern with appendicitis is that it does not rupture before surgery. This is the connection between the small bowel and the large bowel. And it's that connection there. And this has spews contents into the peritoneum, which are contaminants, which makes the whole intestines irritable and inflamed and angry, as they call it. If we have a child who has a ruptured appendix, and that means their pain went away before surgery, that's when you always thought, oh, they're not hurting anymore. There's a problem here. They've ruptured. What is the treatment? Well, as I said, that intestines is angry. It's been infected. So IV antibiotics, nothing to eat or drink. We need to rest that bowel. But even beyond that, we need all the normal secretions not to go down the intestines. So an NG tube on that child. So an NG tube, we need to do good post-op, coughing, deep breathing, sitting them out of bed, walking them still, because we want to get those intestines working. But NG tube, we want to give the IV antibiotics, IV fluids, pain medicines, and the other thing that we don't think about, if that area was infected from peritonitis, that means the skin that we connected after surgery may not have good skin. Watch that wound because it could dehisce. This is a chance of dehiscence of a wound because of the tissue isn't as healthy if it had a rupture. Meckel diverticulum. If you look at the picture, it really tells you a picture. It's the inside the intestines, and this little skin flap, like a skin tab, comes off. It's called a fetal mesenteric duct. But inside that little skin flap is a blood vessel, and it rips off. So what happens? That blood vessel just bleeds. What do you see? Painless rectal bleeding, because it doesn't hurt anything, but you're going to see bright red blood coming out of the rectum. And they need to do surgery on that in order to get it. And it can bleed quite a bit. So they need to fix it, as quick as possible. IBS, anywhere from mouth to anus. When you talk about the irritable bowels, mouth to anus. Now, there's other diagnoses, ulcerative colitis, those are segments, Crohn's disease, again. These are treated by how? Well, usually it's diet, usually medically steroids to help decrease inflammation. They could be placed on some sort of immunosuppressive to stop the body from irritating itself. But diet is one of the big things. They need to be on a diet that keeps their abdomen calm and prevent it from getting irritated. And prognosis is good as long as they're going to be taking care of their diet and do their medical management the way it should. Children get ulcers. You think they get ulcers? I've seen a 6-year-old with an ulcer. He was mom's little, as she said, worrywart. And he was always worried about everything. And he literally had a really horrible stomach full of ulcers. We treat it just like adults, same medicines. And ulcers can perforate just like adults. Gastrectomies can happen with adults. But usually medical manage, and of course through diet, they do get better. And then of course, some of these do need therapy with it, depending. Liver diseases, hepatic disorders, could be due to many different reasons, viral, non-viral, autoimmune, metabolic. It just means that the liver is just not working the way it should. And then hepatitis can occur. And there's how many types of hepatitis out there? I can't even, so many letters. But what do we need to know about hepatitis for children? Well, if we're going to feed them, we need to give them high protein and carbs because they need that caloric intake and they need the protein for muscles, okay? Because that's part of what hepatitis does, but low fat because they can't tolerate fat. Liver digests fat. Liver's not working, you're not digesting fat. What happens? You get bloated, gas pains, you don't want it. So high protein, high carbs. Cleft lip, cleft palate is when the lip, one side, both sides, maybe the roof, the palate, yes or no, all could be open or just one little piece could be open. They're all different. The thing with cleft lip, cleft palate is now you have got an infant and they can't do a proper suck. What do children do to stop stress? They suck, right? Suck, chew, bite. That's what they do. So they're not going to be able to hold a bottle and suck it themselves. So there's things that are being done, especially if a child has the palate also, because they're going to put milk in their mouth, it can come out their nose because there's nothing dividing it. So about 2 to 3 months, the lip, we do that first so that they can get a seal around a bottle just to hold it because that's comforting to them. What they do is they put this Logan bow here, and that pretends, and you see the elbow restraints too, so they can't touch it, because you'll see that your lip is darker. And when they put it together, they have to put those edges, they call approximate those edges real well, or you have a crooked lip, which is, every parent goes, oh, but the lip looks crooked. So they're actually really, really good about getting them good. Now, then that cleft palate. Now, my little Pierre Robin boy had both lip and palate. He was a sick little boy at birth. And usually it says 6 to 12 months, 8 to 12 months, somewhere a little under a year, they're going to fix it. And they're going to do it then because this is when they start saying, mama, dad, start talking. And if you cannot make that seal with your roof of your mouth, you talk like that because you can't pronunciate. So we know speech, is important with these children. So we will get it fixed as soon as we can so the child can learn how to speak correctly from the beginning. Biggest issues is feeding. Now, a cleft lip child, can they breastfeed? Well, if a mother is patient, yes, they can. Many of them, because it's so frustrating for the child, will use these Haberman bottles. You see this bottle right there? That long thing on top is soft. And you put the nipple in their mouth and formula will go into that little area, and slowly you just touch it and squirt slowly into their mouth so that they are thinking they're sucking and swallowing. So it gives them comfort. There's all different things they use for the breasts. There's things they can put on there, but it takes a very special woman to keep a child with only breastfeeding with a cleft lip, but it can be done. Remember, if they don't feed, nutrition, they're going to have problems, cognition and growth failure. So number one, first important thing is making sure the child gets proper nutrition. Now, another thing is when the esophagus does not connect to all the way to the stomach. It's called esophageal atresia, without nothing. And then the other one is tracheal esophageal fistula, which means a connection between the trachea and the esophagus. Either one of them, doesn't matter. You swallow something, where is that swallow going to go? In the lungs. If it can't go down, fills up the esophagus, where it's going to end up going? Into the lungs. And if you put it down the esophagus with its fistula, directly into the lungs. So this child, absolutely nothing by mouth. Now, what would make you suspect that you have a child that has no connections or an extra connection somewhere?
Would they projectile vomit?
They don't, because they don't have a lot of stuff, but just seeing them spitting and spewing and choking on their own mucus because they can't swallow it. It doesn't go anywhere. If they swallow it, it goes down into their lungs. So you hear coughing and spitting, and you'll see them become cyanotic, and that usually will clue it in. Also, if you try to take a NG tube or OG tube, put it in, it won't go down. It won't pass into the stomach because it doesn't go that far at all. So these children need to be placed NPO. They need IV fluids, hyperalimentations to order to feed them. If it's going to be a longer time to get it done, they'll need a gastrostomy tube for feedings on these children. And these children, when we're looking at taking care of them and getting them ready for surgery, you're going to give IV fluids, but because of all of these chances for aspiration, they'll be placed on an antibiotic because of that potential aspiration pneumonia. Treat the infection before it occurs, basically. But you'll see them coughing and choking and spitting. And I've seen one in my lifetime. Kid is normal, absolutely perfectly normal. It's just their connections were wrong. There's no syndrome, there's no delays. They do well. So keep the airway open, keep that pneumonia prevented. Elevate the head of bed, NPO, suction at the bedside. Absolutely. Sometimes they'll go ahead and make these surgical moves in order to buy them time to do the full repairs. But usually IV fluids, antibiotics, until we get to the point where we can do surgery on them. Hernias. Have you ever seen the little belly button hernia? And you push on it and it's soft and it goes in and out. It's called an easily reducible hernia, and they're actually safe because you can do it without pain. When you push on them and they hurt, that's incarcerated, strangulated. That child needs to go have surgery now because it has twisted and the intestines is dying. Now, another sort of hernia that you can have is a diaphragmatic hernia. Think about the diaphragm didn't form and the intestines are up into the chest cavity and it's pushing from the left side over into the right side. These children do not have a left lung, even when we push the intestines back and make a mesh for that diaphragm. These children are extremely ill. Most of them end up on ECMO, like a heart-lung type machine. And for life, they'll have only one lung because that one side never had a chance to form. So these children go through a lot. Respiratory, pulmonary care to get that one lung working as best as it can. Pyloric stenosis is vomiting, but vomiting like the exorcist across the room. This is not GERD. GERD is a dribbling. Whenever I get an infant, small, 3 weeks to 2 months, and they're telling me they're vomiting, I'm going to ask, is it drooling or is it spewing across the room? If it's spewing across the room, it is pyloric stenosis. What happens at the base of the stomach, at the pyloric sphincter, it becomes thickened and muscular. And an osis means a narrowed opening. So food can't get down. So that belly all fills up until it can't go anymore. And then the kid violently vomits across the room. And it's impressive. It's really impressive when you see this little baby vomiting like that. Because of that thickened muscular sphincter, you can feel like a little olive right at the little midline or a little bit to the right, you know, the upper abdomen. And you can tell, okay, there it is. You can feel it. So what is the management? You get a child, you're suspecting pyloric stenosis. You can feel the olive, they're vomiting across the room. Number one, make the child NPO, nothing to eat or drink, because we're going to do surgery. We need to open up that valve. And we don't want that kid to vomit again, because when kids vomit, there's always a chance for aspiration. We don't want that. We're going to start IV fluids on this child, and we're going to bring them up to the OR. These families are young. They just had a baby. These mother and father, they're really upset. I mean, mom's still hormonal from the delivery. So these parents need some special tender loving care. After surgery, these kids do great. They're home within a day or two. They'll place them on some antibiotics just to be safe. And they'll start with clear liquids, and then they'll start feeding them, send them home. Intussusception is like a telescope. So when the intestines go in the other side, it sucks it in. And what happens is, because the intestines are so full of nerves, it hurts. These kids are screaming. Usually these kids, the youngest one I've seen, I believe, was 5 or 6 months old. Usually it's 1 year to 3 years right there. And these kids come in, their legs are just screaming and they're arching and they hurt so bad. And then all of a sudden it comes out and it goes back to normal, and the kid's running around the room looking great. So If we want to go try to find out if this is an intussusception, if the kid is not in pain anymore, you're not going to see the intussusception. Sometimes they will go in and out. So, excuse me, most of the time, these will resolve by themselves. You'll send them home and tell them to put them on a high fiber diet. Keep that bowel moving, okay? And of course, if it reoccurs, to come back. Sometimes it's stuck there, it's swollen, and it can't get out, so the kid's in pain. So what we do is, under fluoroscopy, the radiologist puts in a rectal tube and pumps air into the intestines, and it pops it off, and then the pain stops. And that usually is all they need. Send home, high fiber diet. But about 10% of them need to go to have surgery and have that piece of intestines taken out because it's so swollen. But the intussusception, it's you'll see the kid's going to be hurting so bad. Malrotation volvus is just the body, either during embryonic, it's around an artery and it gets strangled, or sometimes the intestines turns around on itself and make a knot. I've seen them both ways. Think about a malrotation or volvus. They will present, looks like an appendix, but it's not the right lower quadrant. It can be any quadrant in the abdomen with severe pain, because they do the same thing. It causes peritonitis, perforation. All of those things happen with appendicitis too. So again, these children will be in pain also. They're harder to diagnose. Another thing is imperforated anus. You see the picture of that little baby? He doesn't have an anus. So surgical emergency, take them immediately up to the OR. We need to put in a colostomy because your body has secretions. It has to go somewhere. So this child will be with a colostomy for life because there's no sphincter there. There's nothing. There are fistulas that go anywhere. I've seen from the rectum to the vagina. Sometimes we see the bladder to the intestines with urine come out of the rectum. So being aware as we change diapers that the body fluids are coming out of the proper holes is something as nurses that we're going to be watching. Celiac disease, this is what you're talking about, wheat and rye and barley that can cause problems in a child. It's has to do with gluten, gluten sensitivity. They can't eat it. And if they do, what they feel is severe pain in their abdomen, and literally in tears, pain in the abdomen. You're going to see steatorrhea, which is the fat they cannot digest, and you're going to see it coming out in stools. I mean, the stools are pale because you're not digesting any of your food, but you're also going to smell it. Smell this really bad smell. It's malodorous. And you'll say, okay, now I understand, you know, the steatorrhea. You almost sort of see the fat in the stools. So how do we treat it? Literally, it's all about what they eat, and it's a low gluten diet. Short bowel syndrome is when a child's intestines are not as long as they should be, and they've been removed to some reason. Now, the most common reason to remove bowels or a piece of bowels in a child, even the prematures, is something called necrotizing enterocolitis. And this usually occurs due to some hypoxic event, that an area of the bowel was without oxygen, and then we put food in it. And it stressed the area, and it causes the area to die, very simply. This is why when we are taking care of infants, we're measuring abdominal girth. If they have a tube and an NG tube, we're going to be checking for aspirates. Are there any fluid, milk retaining in that stomach? If we see aspirates going up, abdominal girth getting bigger, we're suspecting necrotizing enterocolitis. I had one girl who she was 8 months old at the time, lost 58 centimeters of her small intestines due to necrotizing enterocolitis. She ended up with short gut syndrome for life. That means her intestines cannot absorb things the way we do. She has barely a small intestines in there. And she did have a G tube for the first several years of her life. And she had, the Broviac, where she had hyperalin lipids at night. It could be due to many things. I mean, gastroschisis is when stomachs are born on the outside, and sometimes that can affect, the intestines. And there's another thing that we have, it's called a bladder exstrophy. These are organs in your body, stomach and the bladder, born on the outside. It's like the mid-closure line thing didn't close right, and these are born on the outside. And the thing is, they're still working, they're still fine, they work, but we got to get them on the inside, and we need to keep those areas as sterile as possible till we can move them inside. And of course, nutrition. Remember, they can barely get enough nutrition. They're always fighting. And then we know children, they'll put everything in their mouth. Doesn't matter, they'll put it there. We need to be careful. I think the most common of everything is your vitamins. They love their vitamins, but also they do like to put their ibuprofen and acetaminophen, those pills, and they like to drink that stuff and eat those things. So just be careful with those things. Poison control is our friend. Make sure that if anything happens to call, because it can create a lot of problems. I've seen many different things go into children. I think of all of them, it's vitamins with iron, because now you have too much iron. And I've also seen them eat rat poison, which also causes bleeding coagulopathies. And now we're watching for bleeding on these children. So those are the two biggest things I've seen. Not nice at all. Any questions? Who wants to win a Kahoot? Maybe? Letitia, you look wide awake and alert and ready for it. Oh, he's gonna win. Okay, cool. You picked the colors today. Let me get there. There we go. 50 questions in the Kahoots today, but I'm covering everything and more stuff that I just can't cover everything in a lecture. So I throw it into the Kahoots, and I think I can explain it there for you. Let's get going. GIGU. All of the following are symptoms of dehydration in an infant, except what? So Increased urine output, would that be a sign of dehydration? You're going to have a decreased urine output, okay? You're going to see dry skin, loss of the elasticity, you're going to be lethargic, you're not going to be as alert, decreased urine output, increased heart rate, decreased blood pressure, all of those things. What is priority treatment for a child with dehydration due to profuse vomiting? So IV fluids, we're going to give fluids to this child in IV because we're profusely vomiting. How are you going to try to give a child oral electrolytes? Not going to happen. And, you know, maintain them MPO? No, not for a long period of time. We'll give IV fluids, we'll give something for the nausea and vomiting, and then slowly reintroduce oral. What is the treatment for an infant with diarrhea lasting for 4 days? We talked about vomiting in the treatment. Now we're going to talk about diarrhea. So diarrhea doesn't mean that they're vomiting, which means they can take stuff by mouth. So they don't need IV fluids. So oral electrolyte solution for diarrhea is appropriate, okay? Furthermore, you're not going to stop feeding these children because if you only gave liquid to a child with diarrhea, what's the stool going to look like? Liquid. So you need to give them something to give them a stool. So you would feed them non-spicy, low-fat sort of food to, you know, give them something to make a stool. What acid-base imbalance might you see with a child having profuse diarrhea? You're going to see me throwing in some acid-based questions because there were several on the HESI, and I know they come on the NCLEX. So I'm going to be throwing some important ones in my cahoots just to get you ready. Good. It's metabolic acidosis. In the bowel, there's a lot of alkalotic material because it's coming from the digestive process of, you know, the organs in the small intestine. So yes, it is metabolic acidosis. Good job. Multi-select. If an infant has not passed the meconium stool in the first 24 to 36 hours, what would you assess for? So we're going to worry about hypothyroidism, cystic fibrosis. We've already talked about those. Hirschsprung's disease, we added on today. Yes. Electrolyte imbalance has nothing to do with stooling. So no, that's not what we're going to check for that. Deficiency of vitamin D causes what? So vitamin D deficiency is rickets. Scurvy is vitamin C. Has nothing to do with jaundice. Vitamin D is about joint and muscle. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? That was a mouthful. So we did diarrhea, we did vomiting. Now we have vomiting and diarrhea. And they're saying unable to drink. So IV fluids is all we're doing. Very good. A multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? Remember that appendix is got intestinal debris in it, and it opens and ruptures in that abdomen and makes that peritoneum just inflamed. The bowels are angry. So post-op, what are we going to do? Well, we don't want them on bed rest. We want them up and moving because we want those intestines to start moving again. That's how we do that. IV antibiotics, absolutely. NG tube suction to keep those bowels calm, let them rest. And then assess the surgical site, because who knows if the tissue that they joined was good tissue, because it could dehisce. Very good, remembering that one. Passage of urine, usually at night in children who should have voluntary bladder control. It's called enuresis. Epispadias is when in the male penis, the urethra, instead of coming out on the end, is on the top. All right? Epispadias is on top. Hypospadias is on the bottom. It means it doesn't come out the normal way. So how do we fix that? Well, the circumcision tissue is used to do a plastic closure on it. And then after surgery, to keep the tube open and patent, they put like a little stent in there. It sort of looks like a female straight catheter, that clear thing, and they put it in there, and you leave it alone, and it just drains out urine, and it keeps that tube open. This is my little child who was Pierre Rabin, who also had a hypospadias, and I got to see that tube in action. So I thought that was pretty cool. What is Hirschsprung's disease? Remember, Hirschsprung's is that big bulging and that little tiny little opening with ribbon stools. That's all you're going to see. But there's no nerves, absolutely no nerves. So it stretches. It doesn't care because it doesn't hurt. So treatment, get rid of it, cut it out, and do a colostomy on that child. What type of stools would an infant with Hirschsprung's disease have? Remember the picture, that big out-rounded bowel, and then the bottom, the rectum was little tiny. So what would you see? Said it looks like you should have icing in there and just squirt it on a cake. It's literally that tiny little ribbon sort of stools that you might see. What is a condition that occurs mainly in children when the intestines telescope into itself? And it is intussusception. And treatment is whether it comes out by itself, high fiber diet, or if we do air enema or surgery. But it's also the preventative, trying to keep that fiber. Gastroesophageal reflux disease, GERD. What is that? If you had a younger child, 4 or 5, that had GERD, what would be the signs and symptoms that you would see in them? And that, stomach is going up into the esophagus. Well, you're going to see that kid coughing because it's trying to aspirate. You're also going to see that burning and abdominal pain. And those are your telltale signs in your older children. In young infants, the arching of the back, and it really, you can tell. Inflammatory bowel disease involves what? IBS. So IBS is, remember, mouth to anus, anywhere in between. It's all of it. What would the nurse be looking for with a patient who has a meccal diverticulum? There's that little piece of skin flap, and that little piece of skin flap has a blood vessel in it, and it rips off. And you're going to see, yes, painless rectal bleeding, and it will continue till you go in and get rid of that little diverticulum there. Twisting of the bowel, blocking the lumen of intestines is called which one? Or this is one of those ones that are like an appendix, but you're not going to see the pain in a right lower quadrant. And this is called a volvulus. Intussusception is the telescoping. The twist is a knot, okay? So, and paralytic ischemia, what does that mean? Anyway, volvulus is the answer. And Albert's on fire. A school-age child goes to the ER due to abdominal pain and vomiting for the last day. What assessment is your priority to ask? So they've been abdominal pain and vomiting for the last 24 hours. What assessment is priority? What do you need to know? So you're having abdominal pain and vomiting. You need to know, where is that pain? Is it that right lower quadrant? Where is it? We need to figure out what's going on with that belly. Is it just vomiting due to food poisoning, or is it due to something going on inside? So assessing the abdomen is important. What would the nurse expect to see in an infant with biliary atresia? Biliary, liver, atresia, A, absent, without. That means there's no connection. What does bile do for the body? Well, if you don't have the bile, you are going to see stools that are not colored the normal. They're going to be very pale. And remember, they stink. They really stink on this one also. And of course, you're not absorbing fat, so abdominal distension because of the fat. What structure of the mouth can be impacted by cleft lip and palate? It's everything. It's the lip, it's the palate, it's everything. What is the most common associated syndrome for cleft palate? I mentioned it a couple times with my little guy. He also had a hypospadius. And that is your good old Pierre-Robin syndrome, tiny mouth, problems with swallowing. and it goes into cleft lips, cleft palates, also goes into that hypospadius. It's all different things that you look up Pierre Robin, those are all the symptoms. Cleft lip repair is usually done when? And again, that good old Haberman bottle, which really satisfies that baby because they have something that they think they're sucking on. So we're going to do cleft lip at 2 to 3 months. We try to do that pretty quick, okay? Because we want to put that lip around the breast or around the bottle. This is very important because when you can't nutritive suck, this is what we need to do. When you have a condition that doesn't allow you, whether it's at atresia, tracheoesophageal fistula, when you can't swallow and you can't use eat, you still need that sucking. It's part of that, developmental stages that we need to go through. It's
So
good
Ms.
for cognition. Yes.
So Ms. Bogart, did you say anything in reference to cleft plate about 6 to 12 months? Did you mention that age? What do you do at that time?
Palate is 6 or 8 months to 12, about 6 to 8 months to 1 year old.
Okay.
In that area. And here's this one there. Cleft palate repairs when? There you go. So about that 8 to 12 months. It's that latter half of, the first year of life. Get that lip done first, make sure that they, have that ability to like hold on to a pacifier, and then you go for the palate. Esophageal atresia. What's that? Remember, take these words apart. We know esophagus, atresia, without what? And it's that lack of opening between the esophagus and the stomach. What are the classic signs of esophageal atresia and tracheoesophageal fistula? What would you see? So remember, there's no entry down into the stomach. There's all this mucus that we have normally. This child, infant's going to be choking and coughing and probably getting cyanotic episodes because of all this mucus. It's hard to breathe and there's nowhere to swallow. A neonate with suspected tracheoesophageal fistula, the nursing care should include what? So tracheoesophageal fistula. Between the trach and the esophagus, there's a tube called a fistula. What are you most concerned about there? So we're going to keep this child NPO, or else you're going to feed them right into their lungs, because there is a hole between the esophagus and the trachea, and it's going to go right into the lungs. So elevate the head of the bed, NPO, suction at bedside. A 5-year-old's complaining of epigastric pain and a persistent cough. What would you suspect? Okay. When we have epigastric pain and that cough, that means reflux is going on, which means some can get into the lungs. And that's why the cough, 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 cough. And the pain, because it burns that reflux. Good. Hypertrophic pyloric stenosis. Signs and symptoms, what do you see? So remember that pyloric stenosis is a valve. It becomes hypertrophic, thickened muscle, and you feel that little olive right at the midline or a little bit to the right. And that's one of the things. And then with projectile vomiting. Hypertrophic pyloric stenosis. Projectile vomiting. Literally, watch your shoes across the room. It's going to be splattered. It is that forceful. And a little tiny little 7-pound baby, yes. What does the celiac disease affect? So celiac disease is small intestines. Okay, let me bring you back and let me stop you from thinking large intestines. Celiac disease, you know that food affects it. Where is all the nutrients broken down by pieces of the common bile duct? Small intestines. The only thing a large intestine does is absorb extra fluid out of it, okay? It just absorbs more. Small intestines has to do with breaking food down and absorbing it in. Celiac disease has to do with vitamins. It has to do with the ciliae that's in that small intestine. So hope that helps you. If you have celiac disease, what should you eliminate from your diet? How about just gluten? Wheat, rye, and barley. So remember, when you're looking at foods for celiac, anything that has a bread crust on it or noodle, forget it. Just say no. It's usually what your answer will be too. A multi-select. Vitamins that children with celiac disease are prone to lose are, and we know beyond that, those vitamins are fat-soluble vitamins. So A, D, and K are all fat-soluble vitamins. C is not water-soluble. What foods would you select for a child with celiac disease? What did I tell you what to look for and to keep away from? Anything with bread, macaroni, you don't want it. French toast, macaroni and cheese, has macaroni in it. And garlic bread, absolutely not. Bacon omelet, banana, and glass of milk. That's a nice dip meal. And it's low in gluten. Phimosis, I mentioned that. What is it? So when the foreskin is too tight and you can't pull it back. You know, I have a grandson who's now 5 years old, and at birth, you know, my daughter wouldn't pull it down. I mean, my best friend, she wouldn't do it for her son either. So of course I've been made the person to do it. So I'm trying to pull it. I can't get it down. I tried for several days and I said, you know, it's not happening. So he had to get circumcised because I didn't want that extra schmegma and urinary tract infections on that poor little guy. So it's just a tight foreskin. And that's usually the treatment, circumcision. What is a hydrocele? So hydrocele is just water in the testes, and it is painful. And sometimes it will cause an incontinent moment, and then the pain is what clues them. Antibiotics, is it? What is cryptorchidism? So when you look at, you know, your first visit to a pediatrician with a little boy, infant, one of the first thing they do is check the hips, make sure they work, and then they're going to go in and check for the testicles in there. Cryptorchidism means the testicles didn't come down. Now, one of the things you have to be careful with to make sure that the testicle had every chance to come down is that the room is not cold, that it's a warmer room so that you could have them down, because cold will bring them up. Okay, so as long as the room is warm, you can get a good analogy. Now, they cannot stay up in the abdominal cavity because they will die. It's too hot up there for them. So they need to do surgery to bring them down if they're not down there, you know, in a couple months. You suspect an infant has cryptorchidism. How would you examine this infant? And again, put them in that warm room so you know those testicles are where they should be. And if they're still up, yeah. A hypospadius is so it's knowing what's ventral and what's dorsal. Remember, one on top, one on bottom, which is which. So a hypospadius is the abnormality on the bottom, the ventral portion of the penis. Epispadius is on the dorsal or on the top part of the penis. How do we correct it? We use the foreskin and put a little stint in there. A multi-select. How is a hypospadius corrected? So the foreskin is used, we use a stint. And the surgery is actually done under general anesthesia. It's quite an extensive thing, and you're working with the penis, so it is not local at all. Circumcision is actually, they give sweeties and little sugar water and a pacifier, nothing more than that. Local? No, not at all. General anesthesia. What is bladder exstrophy? I mentioned it with gastroschisis. So the bladder exstrophy, again, is that midline closure that don't work, that happens somewhere, you know, in the embryonic period, and the bladder is left on the top. And as I said, it still works perfectly, still drains urine, still holds urine, but we have to keep it sterile so we don't get infection. That's our highest priority. And then eventually we'll get it put back into the tummy, but we've got to like keep making room in order to get it in there. What are the clinical manifestations of nephrotic syndrome? So it's all about proteins and swelling, hypoalbuminemia, low serum albumin, peripheral edema. We treat it with some steroids, nursing care, I and O daily weights, low salt diet, and monitor and restrict fluids. Children with nephrotic syndrome are often given what medications for fluid overload? Remember, nephrotic syndrome, the vessels, the vasculature, the blood doesn't have enough protein in it. So you see a lot of fluid going interstitially. You give this child albumin, which is protein. So it goes back into the vessels. It pulls out the fluids interstitially. Then you give Lasix behind it and you're going to have a massive output, which is what you want because you want to get rid of that swelling. Good job. For those who got that one, that was a hard one. What is used to treat nephrotic syndrome in children? And it's prednisone. Prednisones are done because it decreases the inflammation. And then, of course, we're going to get protein back, et cetera, and then continue on the low salt diet and watching fluid restrictions. What is the priority nursing care of a child with nephrotic syndrome? Priority nursing care. And that is I&O and daily weights. Excellent. We're going to see if we're doing something right. The weight should be coming down, get rid of all that extra fluid. Should. Why is erythropoietin used in chronic kidney failure? What is erythropoietin?
It's what your kidneys make for red blood cell production.
There you go. Absolutely. Because we know kidneys and kidney failure tend to have low hemoglobin hematocrits. So we give erythropoietin to make red blood cells so it can decrease the amount of blood transfusion this child might need. So it's a really good thing to include in a child with chronic kidney disease. A multi-select. Children with CKD have renal osteodystrophy. What can this do to the child? What is renal osteodystrophy? Well, we know osteo. What does that mean? What does dystrophy mean? So with just osteodystrophy, is something with the bones that's just not right. High parathyroid levels is high calcium, which causes growth retardation and skeletal abnormalities, okay? Uric acid's all about the kidneys. It has nothing to do with the osteodystrophy portion of it. That's just about the failure. But osteodystrophy is something we need to look at with those high calcium levels and keep them normal to prevent the growth retardation and those skeletal abnormalities. A diagnostic finding of acute glomerulonephritis may be. I'm asking this question in a different way. Let's see who gets it. Does it matter? Rheumatic fever, acute glomerulonephritis. They're both caused by the same thing. And that ASO titer, look what's in the middle of anti-streptolicin. It's about strep, okay? ASO titer. This is one way that you will see this presented in the lab form. So Instead of saying strep throat recently, it's a positive ASO titer. We'll say, okay, that's the answer. What complication of peritoneal dialysis is most important? Remember, dialysis in the peritoneum, you only have one way of delivering it. And if we get peritonitis, we are in trouble. How would we know? The fluids would change colors, there'd be sediment, it just wouldn't be looking right. And when in doubt, you know, better put them on antibiotics, because that is your kidney, that's all you have. Which clinical assessment is most important to report with a child diagnosed with acute kidney trauma? I had this one little boy playing outside, was running, was backwards, and his back, right at the kidney level, hit a hitch on some trailer. And he came in with this huge bruising on his back. And the biggest thing was when I saw the lab values, his potassium was above this. I think it was like 7 point something. Of course, we're going to be concerned about, you know, think kidneys, think potassium for sure. It's always elevated, but with trauma, you do see that. And then what would be concerned about is, you know, cardiac dysrhythmias, because it is an elevated potassium. Low or high can cause cardiac dysrhythmias. I'll multi-select. What should the nurse anticipate for a child who just had a renal biopsy? Remember, I told you a lot of this is similar to a cardiac catheterization. We're going to have a sandbag on the area if we possibly can. Kid is not getting out of bed. He is staying in bed. We're going to monitor that dressing for urine or blood. And of course, we've just touched the kidney. Intake and output are very important. Good job. What would you do if the fluid draining from the peritoneal dialysis had changed color and is now cloudy? Absolutely, there's an infection, peritonitis, something's going on. Notify the provider. When in doubt, call them, place them on antibiotics. And last question, what would the nurse provide to an infant that cannot eat normally? So the big thing is we're not putting anything in anybody's mouth who can't eat. What if they had tracheoesophageal fistula? It's gonna go right in the lungs. Nothing, not milk, not water, but we want to give them that non-nutritive sucking. They pacifier, it's so important. It's just for proper development. Number 3, how'd we do? Albert, good job, Albert. Whoop, whoop. Number 2, Jessica, good job, Jessica. Number 1, Ari, because she had proper dinner. Lamika and Claudia, good job, guys. If you do me a favor, sign your attendance attestations, make sure you get them done so that we don't miss them. One thing I wanted to tell you is in Kaplan, the thing that's asked for, it's said incorrectly. The word should say Advanced Math Peds A, okay? It says it differently, or Math Pediatrics A, but it's Advanced Math Peds A is what the one to do. There's only one like it. I was asked if they use circumcision on an older child. An older child will go to surgery and be knocked out. A younger child, the infants, they just do it right there in the office, usually the OB's office, and just get it done. Oh yeah. And they just put sugar on a pacifier, and they actually do really well with it. I heard my grandson cry and I was like, oh, I want to be there. They wouldn't let me go back though. Anyway, thank you, everybody. Any questions? Okay, if you need anything, just holler to me. Thank you so much, guys.
Thank you.
Always.